Hello, everyone, and welcome. Thank you so much for joining on time. We will be beginning our global webinar very shortly, but before we officially start, I would like to do a quick sound check. Please, if you can hear my audio very clearly, show or type actions. Thank you. Perfect. All right. We'll begin our global webinar now. Good day, good morning, and good evening to everyone joining us from different parts of the world. My name is Emmanuel, and I'm joining you today from Rwanda. I serve as committee member with the Operating Room Global Education and Training Committee. On behalf of the Operating Room Global and the TORG Global Education and Training Committee, it is my distinct pleasure to welcome you to today's global webinar. We are pleased to have a truly multidisciplinary audience with us today, including surgeons, anesthesia providers, nurses, surgical technologists, perfusionists, educators, researchers, students, and healthcare leaders. We are currently joined by participants from multiple countries across different time zones, and we sincerely appreciate your time and commitment to continuous learning. Whether you are joining us from Africa, Europe, Asia, the Middle East, the Americas, or elsewhere, you are very welcome. Good morning to those joining early in the day, good afternoon to those in the middle of your day, and good evening to those of us joining later. We are grateful to have you all with us. We strongly encourage active participation throughout the session. Please use the chat box to introduce yourself by sharing your name, professional title if applicable, and country. Also post your questions and comments at any time during the presentations. Our moderation team will be actively monitoring the chat and will bring your questions forward during the discussion segment. For those joining a TORG session for the first time, the Operating Room Global TORG is a multidisciplinary professional platform representing over 260,000 surgical and perioperative professionals across more than 110 countries, making it the largest global network of operating room professionals worldwide. TORG brings together 42 healthcare disciplines and specialties currently and operates as a not-for-profit and a non-governmental organization founded in Nigeria in August 2015. Today, TORG has over 20 active chapters globally, including representation across 31 African countries. Our mission is to advance surgical and perioperative care through education, research, advocacy, innovation, and capacity building with a strong focus on safety, equity, and system strengthening. TORG is an international accredited continuing professional development provider recognized by the CPT Group, underscoring the quality and global relevance of our educational activities, and is supported by its academic and innovation arm, the Operating Room Global Center for Education, Research, Innovation, incorporated in Ireland, which leads our global agenda in education, research, innovation, and partnerships. Our affiliated journal, the Operating Room Journal, is an open access, peer-reviewed international journal inaugurated in May 2025, providing a platform for high-quality evidence that informs practice and policy worldwide. TORG is proud to host its own institutional review board, TORG IRB, officially registered with the United States Office for Human Research Protections, reinforcing our commitment to ethical, responsible, and globally credible research. TORG is driven by a volunteer-led leadership model held by professionals who contribute their time, their expertise, and their vision to strengthen global surgical care. We are actively engaged with global alliances, including the G4 Alliance, Intersurgeon, and are listed with the Union of International Associations, UIA, and the Global Civil Society Database, reflecting our global accountability and reach. Thank you again. To introduce our first guest speaker, it is my pleasure to hand over to Aditya Sachi to introduce our first guest speaker. Thank you again for joining.
Thank you so much. So it's a good day, distinguished colleagues and members of the operating room global community. Our next speaker is Onone Munashimo, a fifth-year medical student at Babcock University, Nigeria, currently undertaking his clinical training at the Babcock University Teaching Hospital. Munashimo has a strong interest in surgery, trauma, care, patient safety, and global health. He serves as the Babcock University representative for the International Association for Student Surgical Societies and has been actively involved in student leadership, community, and health outreach programs, voluntary blood donation initiatives, and student welfare activities. He is also engaged in surgical research and co-authored the study Peri-Operative Safety in West Africa, aligning orthopedic residency training with system-level gaps identified from DHS SPS data back from 2015 to 2025, which was presented at the West African College of Surgeons' 66th Annual Conference and later at the Babcock University Association of Medical Students Clinical and Scientific Conference. Today, he will be speaking on initial trauma assessment and emergency decision-making and polytrauma. Please join me in welcoming Onone Mushimo.
Good afternoon, everyone. Can you hear me?
I can hear you perfectly.
Okay, thank you. So I'll be sharing my screen now, and my topic will be initial trauma assessment and emergency decision-making in polytrauma. My name is Onone Munashimo, and at the end of this lecture, there are some objectives I want us to achieve. One, we should be able to define what polytrauma is, understand the principles of trauma assessment, apply the advanced trauma life support protocol, make appropriate emergency decisions during the first hour, which is referred to as the golden hour, recognize situations requiring damage control surgeries, and appreciate the rules of multidisciplinary work. So why should we care about trauma? Trauma causes approximately 4.4 million deaths every year and is the leading cause of death for individuals under the age of 45. Road traffic injuries cause approximately 1.19 million deaths annually in Africa and occurs annually in the world, and Africa accounts for 19% of that, despite the fact that Africa only has 3% of the world vehicles. The WHO African region has the highest road traffic fatality rates in the world, which is estimated at 26.6 deaths per 100,000 individuals, compared to a global average of 17.4. Over 90% of trauma deaths occurring in low and middle income countries, despite these countries having fewer motor vehicles than high income countries. But what is really the problem in Africa? The problem is not that we have bad drivers, but the problem is there is poor assessment, limited resources, and inconsistent trauma systems in Africa. Moving on, what is trauma? Trauma can be defined as physical injury that is resulting from external force. It could be mechanical force, thermal, electrical, or chemical forces. What is polytrauma? Polytrauma refers to multiple severe injuries causing physiological instability and requiring coordinated multidisciplinary management. understanding the principles of trauma assessment. So in this aspect, I'm going to ensure that everyone understands what the principles of trauma assessment entails. Number one, prioritization of life-threatening conditions. The greatest risk to be attended to first. It's important that we prioritize physiological injuries over anatomical injuries, and we take a structured and systematic approach in the management of trauma patients. Assessment and treatment occur at the same time. For example, if you're managing the airway, it's better that you secure it immediately before moving on to breathing or before moving on to circulation. Trauma assessment is dynamic. Patients should be reassessed after every intervention, and whenever the patient's condition changes, measures should be taken. Multidisciplinary teamwork. Trauma care requires collaboration among emergency physicians, surgeons, anesthetists, nurses, radiologists, and blood bank staff. Patient safety should also be a priority, as there should be limited cervical spine motion, and hypothermia should be prevented in these individuals. Now, for proper understanding, there's a clinical case that is being painted here. A 27-year-old male brought to trauma facility from a high-speed road traffic collision. Patient's vitals: blood pressure 80/50, pulse rate of 140, respiratory rate of 32, oxygen saturation of 86%, Glasgow Coma score of 10, and open femur fracture. Now let's go into advanced trauma life support. And as you go on, see how this can be managed adequately. Beginning, there are 9 steps in this protocol. The first being preparation, triage, primary survey, adjunct to the primary survey, consideration of the need for patient transfer, secondary survey, adjunct to the secondary survey, continued post-resuscitation monitoring and evaluation, and definitive care. Now, under preparation, where does trauma assessment actually begin? Trauma assessment begins in the field with the help of our first responders and paramedicals. Deficits in this area leads to worsening clinical presentation when these victims finally present to the hospital. And this is also one of the reasons why Africa has a poor outcome for trauma patients, because we lack proper first responders and paramedicals. Under the preparation phase of advanced trauma life support, we have the pre-hospital phase and the hospital phase. In the pre-hospital phase, what is done? Our first responders and paramedicals ensure that the airway is being maintained, external bleeding is controlled, mobilization of the patients, and immediate transport to the closest appropriate facility. They also provide necessary information to the healthcare providers about the accident that just occurred, so that at the time it happened, events that are related to this injury, and a brief history. Now, this is a decision scheme that is used by our first responders. First of all, a Glasgow Coma scale less than 13 indicates that this patient will be transferred to a trauma facility. A systolic blood pressure less than 90 indicates that the patient will be transferred to a trauma care facility. Respiratory rate less than 10 or greater than 29 breaths per minute indicates that the patient will be sent to a trauma care facility. All penetrating injuries should be sent to a trauma care facility. An adult that's fallen from a height greater than 20 feet should be sent to trauma care facility. Children should be sent to trauma care facility. Older adults, geriatric patients should be sent to the trauma care facility. Pregnant women also should be sent to the trauma care facility. Also, for individuals that have experienced any trauma as regards the chest area, should also be sent to the trauma care facility. If the first responders are worried about the outcome of these patients, they should also be sent to trauma care facility. Now, our patient in the clinical case that I painted has a Glasgow Coma scale less than 13, so this patient will be sent to trauma care facility. Moving on, the hospital phase of preparation. In the hospital phase, trauma timeout is the first step. This is where the emergency physician prepares the trauma team for management of this patient. There's trauma resuscitation, that's the actual resuscitation that is being done. And after resuscitation is done, a debrief is done so that trauma team can think properly. What went right? What could we have done better for this patient to have had a better outcome? Now we are moving on to triage. What does triage involve? This involves sorting patients based on the resources required for treatment, the resources that are actually available, and the severity of the trauma. Now, in this picture in my slide here, you've seen that red is given for immediate patients. These are patients that have had severe bleeding, patients that are in shock, or patients that require a proper airway that should be set in place. Yellow is given to patients with stable fractures but have large wounds. Minor cut sprains are given to a green patient. Now, from this case I painted, our patients will be given a yellow brace. And it's important that appropriate role assignment is done. And triage should not intervene. I use the word intervene. Should not interfere, rather, with the care that is given to these patients. So, primary survey of the ATLS protocol. We have 5 steps in the primary survey: airway maintenance, breathing and ventilation, circulation with hemorrhage control, disability, exposure and environmental control. How does examination of the airway first begin? It begins with assessing speech. The ability of a patient to speak, tell you his name, or what event happened is a sign that the patient's airway is patent. If the patient is not responding or speaking when you speak to them, when you ask them a question, but I inspect the injury for foreign bodies, identify any facial fractures, and suction away any blood and secretions. Any patient with the Glasgow Coma scale less than 9, an airway should be set in place. Patients should be intubated. Now, while assessing patient's airway is important to prevent excessive neck movement. That's why a practitioner is assigned the position of holding the patient's neck in place to prevent excessive motion. And then after airway has been checked, a neck collar is put in place to restrict neck motion. Now, in the picture that is here, we are seeing that a patient with the Glasgow Coma scale less than 9 does not have sufficient respiratory effort, is actively vomiting, or has any oropharyngeal bleed, should be intubated. The obstruction that is whatever is blocking the airway should be removed, and an airway should be placed for the patient. All trauma patients must receive an oxygen mask. Now, moving on to breathing and ventilation. It's not just a patent airway that is indicating that a patient is breathing well. Ventilation requires adequate function of the lungs, chest wall, and diaphragm. Therefore, clinicians must rapidly examine and evaluate these components. First of all, patient is exposed. Chest area is exposed and examined, and supplemental oxygen is given, as I said previously. Now, you expose the patient and check for important things. Is there an open wound on the chest? Is there any tracheal deviation? Is there any paradoxical chest movement? Paradoxical chest movement just means when the patient breathes in, the chest goes inward instead of outward, and vice versa for breathing out. Hospital examinations should also be done to assess for cyanosis, skin color, respiratory rate, pulse oximeter. Auscultation should be done to assess for the breath sounds, and it's better to think of quick respiratory killers such as flail chest, open pneumothorax, tension pneumothorax, and that these conditions are attended to before moving on to circulation. Circulation and hemorrhage control. Hemorrhage is the leading cause of preventable deaths after trauma injury. It's important to note that in the case of massive hemorrhage control should be attended to first in trauma assessment. What do you assess in circulation? Level of consciousness. You check, is this patient conscious? Can this patient speak well? If I give a command like, oh, raise your leg, raise your hand, can this patient answer me? If the patient cannot, they sign that there's reduced cerebral perfusion. You also check for skin perfusion. Is patient pale? The hypovolemic patient would be pale. You check for the pulse. If it's a rapid and tragic pulse, it's in case of hypovolemia. Bleeding control. First step in bleeding control is applying direct pressure on the injury sites. Use of tourniquet, establishment of vascular access, and use of antifibrinolytics. Why using tourniquet? It's important that it's only used when direct pressure is not sufficient to stop bleeding. And for every patient from trauma, 2 IV wide bore cannula should be inserted for admission of fluid, blood, and medications. Moving on to disability. Disability basically entails checking for the neurologic status of these patients, and this is usually done with the Glasgow Coma scale to assess for eye, verbal, and motor control. Another level of consciousness in case the need to immediately evaluate these patients as regards airway, breathing, and circulation. Exposure. This is the last part of the primary survey. It's important that this patient is completely undressed and is examined from head to toe to ensure that no injury is being ruled out. Adjunct to primary survey. These are basically diagnostic and monitoring tools that are used during initial assessment to monitor the patient's physiological status and guide resuscitation. Examples include use of chest X-ray, pulse oximeter, pelvic X-ray, urinary catheter. During the primary survey, the evaluating doctor typically gets information that tells the patient might need to be transferred to another facility. It's important that transfer is not delayed, and if for any reason transfer is delayed, it's for conditions that are at immediate threat to this patient's life. Reasons for transfer could include injuries that exceed the capabilities of the current hospital, need for specialist trauma care, need for advanced imaging or interventions that are not available locally, requirement for emergency surgery, or limited resources. Secondary survey should not be done until the primary survey is finished. And secondary survey is made up of 2 main parts: history and examination. Under the history, for trauma patients, a long history might not be able to be taken. So use a short history without running ample. Allergies, medications currently used, past illnesses, any history of pregnancy, last meals, events surrounding the injury, and the mechanism of the injury. For mechanism of the injury, when you know how an injury occurred, it's very possible to say, oh, what could be wrong with this patient? Or what might have happened? For example, during a road traffic accident and a side impact, it's important that you check for contralateral neck sprain, any head injuries, any cervical spine fracture. For a patient that's fallen from a height, head injury to be assessed, spine injury should be assessed, any injury to the abdominal viscera should also be assessed. Moving on to secondary survey. Moving on to the examination part of the secondary survey. Another thorough examination is done from head to toe again. You assess the head, maxillofacial structures, cervical spine and neck, chest, abdomen and pelvis, perineum and genitalia, musculoskeletal system, and neurologic exam. Adjunct to the secondary survey. This involves diagnostic tools that will be used to properly assess what might have gone wrong with the patient. An echocardiography can be placed to assess the activity of the heart. An imaging of the spine could be done to assess for spine injuries. And an X-ray could be done for the limbs to assess if there are any other fractures, like in our patients. Re-evaluation. Trauma patients must be re-evaluated constantly to ensure that new findings are not overlooked, and to also ensure that patients are getting better rather than getting worse. It can be done by monitoring of vital signs, oxygen saturation, and urinary outputs. For adult patients, urinary outputs should not be less than 0.5 mL per kg per hour. And for children that are greater than 1 year old, an output of 1 mL per kg per hour is what is adequate for them. Arterial blood gas should be done to rule out acidosis in any trauma patients. Definitive care. This is the last, or let's say second to the last phase of trauma management, in which injuries are fully treated after life-threatening conditions have been identified and controlled first. Now, moving on to the auxiliary part of trauma management. This involves record and legal consideration. For every patient that comes into trauma care, it's important that appropriate documentation is done and recording of timing of key events and treatments that were done to take care of this patient. It's important that someone from the team is assigned this role. Clear records facilitate continuity of care and provide medical legal protection for the doctors attending to this patient. In the case of any criminal activity alongside patient injury, it's important that evidence should be preserved. Clothing, bullets should be preserved. When items are handed over to law enforcement, it should be documented. And blood alcohol and toxicology may need to be tested when legally indicated. Teamwork in trauma care. Effective trauma care management depends on coordinated multidisciplinary team led by a designated team leader. Before the patient reaches the hospital, individuals should assign their roles in the management of these patients. And during resuscitation, team members are to communicate with each other, verbally projecting their voice for each assessment that is done for every patient. Thank you so much. These are my references for this presentation. Please, if there are any questions that could be typed in the chat.
The questions will be communicated in the chat box shortly, sir. Thank you so much for your incredible presentation. And I believe it is really insightful. And obviously, we have learned a lot from your presentation. Thank you so much for that. Let's kickstart with our second speaker. Our next speaker is Samuel Gisline Jr. Fado, a fifth-year medical student at Catholic University of Cameroon, a multi-award winning researcher, leader, and advocate of global surgery. Samuel has authored and co-authored more than 10 research publications and has presented oral and poster abstracts at several international scientific conferences across Africa. His work spans perioperative medicine, cardiothoracic surgery, public health, and surgical systems strengthening. His commitment to advancing research and evidence-based practice earned him selection as a scholar of Pan-African Organization for Health Education and Research, POHER, one of Africa's leading research mentorship programs. He currently serves as a co-chair of Incision Cameroon, where he promotes global surgery advocacy, research, and student engagement. He also served as a conference fellow for TORG KHR 2025 scientific conference and has actively contributed to research workshops, community health initiatives, and leadership programs. Beyond medicine, Samuel has developed a growing interest in diplomacy and youth leadership through his participation in the Yale Model African Union conferences in Nairobi and Accra. In recognition of his outstanding internship, leadership, collaboration, and policy engagement, he was awarded the prestigious Kofi Annan Award for the collaborative stage and leadership at the 5th Yale Model African Union conferences in Ghana. Today, we will be speaking on perioperative challenges and patient safety in polytrauma care. Please join me in welcoming Samuel Gisline Jr. Fado.
Hello, everyone. Can you hear me?
Yeah, you're perfectly audible.
Thank you so much for that. Sorry. Okay, thank you so much for that warm introduction. Like she rightly said, I'm Samuel, a medical student expected to graduate in 2028, and I'm honored to currently serve as the co-chair of the International Students Surgical Network Institution Cameroon. And I'm very glad to be talking about polytrauma following road traffic accident with an emphasis on clinical reasoning, and I'll be sharing my perspective as a medical student. And We shall have the following learning objectives: to define clinical reasoning in polytrauma, recognize its role, the role of every discipline in trauma care, understand the role of medical students in perioperative care, and highlight the importance of clinical reasoning in polytrauma. And as an outline, we're going to start with an introduction and conclude with lessons learned from my experience in the surgical and perioperative care ecosystem. I have no conflict of interest to declare. So as an introduction, it's important to note that polytrauma is a leading cause of mortality and disability worldwide, accounting for nearly 9% of deaths annually. And I'm very happy that Mona Chimso dwelled extensively on polytrauma, its burden, and its management. That makes my presentation much easier. Thank you, Mona. And polytrauma represents a significant economic burden because mortality and morbidity apart, polytrauma is an economic burden with prolonged intensive care and hospitalization, and a social problem with numerous work days lost and cost of care of the disabled. Imagine someone who has had an above knee amputation, their life will unlikely be the same again. They would have to maybe resign from their work and so on. And timely, appropriate and multimodal disciplinary management is essential to reduce mortality and improve outcomes. And in countries like Cameroon, in low and middle income countries like Cameroon, where there's workforce shortage, medical students play a very crucial role. And we're going to understand why further in this discussion. Now, polytrauma, its basic definition is when a patient has sustained multiple injuries. And the management of patients with multiple traumatic injuries presents a variety of challenges. Patients usually require multidisciplinary evaluation, securing the airway and breathing, hemorrhage control, resuscitation, and stabilization in the emergency department, and possible operative intervention before inpatient admission. And the immediate management priority is stabilizing and resuscitating the patient. And there is usually need for an organized approach. Unfortunately enough, the previous speaker dwelled extensively on this. But basically, this is what the primary survey would consist of. The new approach, this was a recent change, consists of an X before the usual A, B, C, D, E. X refers to controlling any life-threatening bleeding before moving on to assessing the airways and then breathing and then circulation, disability, and exposure, as we all know. Now, what is clinical reasoning, which is the main emphasis of my topic? Clinical reasoning is basically the cognitive process healthcare professionals use to gather patient data and use this data to make informed decisions, diagnosis, and treatment. We've probably been in situations where a physician sees a patient and based on just the clinical presentation, they tell you that this is most likely to be this or that. That's not magic. It's not voodoo. It's most likely clinical reasoning. The patient is the physician using the patient's information combined to their previous experiences and combined to what they have seen in the past to be able to make a most probable diagnosis. Now, in polytrauma, you usually have multiple injuries, each one of them competing for attention. You have bleeding, you have the patient gasping, you have the patient's family, and decisions are often made with incomplete information. When the patient is unstable, you're not going to be interested in knowing whether he's diabetic or hypertensive initially. So initially, you have to make a decision without having complete information. And some errors can usually lead to preventable death, and medical students can contribute or prevent some of these errors. It's important for medical students, as medical students, we are learning, right? So it's important for us to study at home, know the whole process, but the main place to learn this in practice is in an emergency setting. And it's also important to ensure that our learning process does not get into the way of providing care to the patient. So we're going to understand how a medical student should contribute to care provision without being a barrier to care delivery. And clinical reasoning in the context of polytrauma usually means this. Understanding the mechanism of injury and being able to deduce the potential injuries the patient has based on the mechanism described, which the previous speaker elaborated on extensively, and also being able to reach a probable diagnosis based on the patient's presentation and use this initial diagnosis to guide investigations and management. And as medical students, it's important for us to learn how to anticipate the injuries simply based on the mechanism of injury rather than waiting for imaging, especially in low resources, things like Cameroon or Nigeria or some other countries where you might have a CT scan, but there is no power, or you might have a CT scan and it's not functioning. So it's important to be able to have an idea of what injury the patient might have while waiting for the imaging. And also, it's important for us to practice ATLS as medical students on every single patient we have the opportunity to practice it on, because we might feel like we know it well until you're faced with the patient one-on-one and you have to apply it on your own. So, trauma assessment, Muna dwelt on this extensively, but it comprises of a primary survey, secondary survey, and after that, usually the patient would be transferred, would be admitted in a surgical ward or in an intensive care unit, depending on the gravity of their situation. And one thing I found very helpful as a student is not limiting myself to the emergency room. It's impossible to follow up every patient to the ward, but it's possible to follow up one or two. So after the patient has been stabilized and sent to, let's say, the ICU, I think it's very important for all students to follow the patient to the ICU. Again, we cannot follow every patient, but we can try to follow one or two. Why is it important? Because it helps to build a rapport with the patient, first of all. And secondly, it helps us to learn medicine better. In the emergency unit, the emergency physician is not always interested in posing the most plausible diagnosis. Usually, they want to stabilize the patient and keep the patient alive. Now, when the patient is stable and is been admitted to the ICU, that's where the doctors have more time to think thoroughly on what could be wrong. And that is usually where you would get the most correct diagnosis of that patient. So when you follow up the patient, you get to understand what mistakes the emergency physician might have made and what should have been done rather. So that's one thing I found very helpful, following up patients right up to the intensive care unit or whichever ward they are admitted in. And also, polytrauma requires multidisciplinary teams, right? The nurses, the laboratory technicians, the radiologists, and so on. And this picture is a picture I love very much because right here we have myself with a black cap. We have opposite me a nurse, and the third person is a consultant surgeon. So we had completed an operation, and the surgeon asked me to close. I said I wasn't very versed with. I told him I wasn't very sure. He said the nurse should teach me. And I was wondering, why would the surgeon ask a nurse to teach me how to suture? But I came to understand that when it came to suturing, the nurses knew it, were very skilled at that because that's something they do very often. And also by asking a nurse to teach me, a medical student, that helps to build some sort of relationship with the nurse, and it helps to break the silos. Doctors on their ends and nurses on their end. Having a nurse teach a medical student indirectly fosters a good relationship between the future medical doctor that I am and the nurses. Above all else, it's important to ensure that the patient is safe, right? As much as we want to learn, we don't want to cause any harm to the patient. And in low and middle income countries, it's usually difficult for physicians to keep a close eye on every single patient, especially when there's a mass casualty, and I've been a witness to this. Students can be very resourceful in monitoring a single patient closely. Usually when I'm on call, there will be maybe 5 other medical students or maybe up to 10 at times. And usually there will be 2 or 3 physicians. And these 2 or 3 physicians cannot monitor every single patient. But we as medical students can help in keeping a close eye on every patient, identifying maybe early signs of deterioration, and doing well to inform the physicians in a timely manner to help improve outcomes. And these could be things as little as vital signs monitoring, checking the patient's level of consciousness frequently, their urine output, and so on. This also helps the student master their clinical assessment better. And sorry, some safety measures that can be used to improve patient safety and also sometimes predict outcome are trauma checklists, clinical prediction scores like the injury severity score, the new injury severity score. Most of these scores don't require too much to be able to apply. We have the RAPS, which means the rapid acute physiology score. We have the rapid emergency medicine score. So as a student, you could try to apply some of these scores to better understand what factors contribute the most to outcomes and help predict the patient's outcome. This doesn't cost you anything and it doesn't cost anything to the patient either. Then sometimes there is need to escalate care. Escalation of care basically means obtaining higher level of support, moving the patient from the emergency room to the operating room, and it could be due to a couple of reasons. And as a student, I think it's important. The most important thing to understand here is, when should I refer this patient? Nobody knows it all. So as a student, it's important to understand when to refer and which specialist to refer to. Because if you call the wrong specialist, you're wasting time, and usually time is life in the emergency setting. So that's one thing I believe medical students should be heavy on learning. When should I refer and who should I refer to? That's as far as escalation of care is concerned. And sometimes the students too should aim to be part of that escalation process, right? If they're moving from the emergency room to the theater for a splenectomy, as a student, if you believe that you already have the basic skills, then you should aim to assist. If things work, if in your country things work like in my country, medical students are allowed to assist on surgeries, because that would help you learn, right? That would help you understand that pathology better, and that will also help you learn how that particular surgery is performed. We know that most African countries have very limited surgical workforce, and they are only able to survive because of task shifting, which is non-surgeons practicing surgery. And the emergency setting is not the place where you want to come and learn the name of instruments. So if you have the basic knowledge and you believe you can be resourceful enough for that particular surgery, fine. But if you cannot, then you may want to learn surgery on non-emergency cases and then come and assist on other emergency cases. So, in a nutshell, talking about clinical reasoning in polytrauma, what I've learned over the years is that early recognition is very important, and as a student, you can contribute to this early recognition by being keen and by being focused on one patient. The ATLS approach is very important in choosing the right priorities and in missing important life-threatening conditions. And communication is very important. It's important. Patient safety requires vigilance, keeping an eye on the patient's vitals, level of consciousness, and clinical reasoning is continuous. It's a continuous process. We learn every day. Each patient we see teaches us something new. And each team member is just as important as every other team member. The doctor is not more important, the nurse is not less important. Everybody has a role to play, and it's only by collaborating that we can ensure the best quality of care is provided to our patients. On that note, I thank you all for your keen attention. Here are my references, and I would love to connect with each and every one of you. Thank you.
Thank you so much, Samuel. That was quite an insightful session. Hello, everyone. My name is Dr. Ian Sote, and I will be introducing our third and final speaker. So our next speaker is Elham J. Jamal, a fifth-year medical student at Jimma University, Ethiopia, with a strong passion for surgery, research, global health, and healthcare leadership. Alongside her medical training, Elham has demonstrated remarkable commitment to professional development, policy engagement, and international collaboration. She currently serves in several leadership capacities, including the East Africa Regional Policy and Training Coordinator and also the Director of Professional Exchange at the Ethiopian Health Professional Students Association, that is EHPSA. She is also an OMLA, or 1 Million Leaders African Fellow, reflecting her dedication to developing transformative leadership skills for healthcare and societal impact. Elham has actively contributed to research and academic initiatives through her role as a volunteer research assistant for the Regional Assessment of Lower Limb Amputations in Sub-Saharan Africa, RAMPS, study at Jima University Medical Center, which was coordinated. Also gained research experience as a research intern at Cytobiz Medical and Innovation Hub in Nigeria. Her commitment to advancing global surgery is reflected in her roles as a Surge Hub ambassador for the Global Surgery Foundation and an ambassador for the Magister Chiugai, the Association of Future Surgeons. Through these platforms, she continues to advocate for surgical education, professional exchange, and opportunities for future healthcare professionals. Today, she will be speaking on post-operative deterioration, critical care, and multidisciplinary follow-up in polytrauma care. Please join me in welcoming Elham J. Jamal. Thank you. Jamal, the floor is yours.
Oh, thank you so much, Dr. Ian. It's really a pleasure to have the chance and opportunity to be the one who is sharing my perspective on behalf of my medical fellows in Jima University. So before I dive in, I would say good morning, good afternoon, or good evening, ladies and gentlemen, for wherever you are. My name is Dr. Elham J. Jamal. I'm a medical intern at Jima University Medical Center, representing Jima University from Ethiopia. So before I dive in directly to my today's discussion, for the sake of being on the same page and for the sake of easy discussion, I want you guys to imagine I want to give you a clinical scenario. Okay, imagine a young patient, who have been involved in high-speed road traffic accident, and the patient arrives with multiple injuries, significant blood loss, chest trauma, abdominal injury, and long bone fractures. And let's say the trauma team performs the initial resuscitation, identified the major injuries, and took the patient urgently to the operating room. And the bleeding is controlled, and the damaged organ has repaired, and the fracture may be temporarily stabilized, and the dangerous part has already passed, let's say that. And however, after the patient is transferred to the general ward 4 hours later or 5 hours later, we have noticed that the respiratory rate is increasing, the heart rate is increasing, and the urine output is falling, and the patient is becoming restless and confused. So at that point, the most important question is no longer, was the operation successful? No, the operation was successful and the patient is transferred to the general ward. But the more important question now becomes, why is the patient actually deteriorating? And can we really identify and reverse the cause before the patient actually collapses? That's the very, very important question that we have to focus on this. So this will be the focus of my presentation today, and to guide this discussion. I will begin with the main objective of my presentation. So the first objective is to recognize early post-operative deterioration. Deterioration rarely begins with a sudden cardiac arrest or with a sudden collapse. In most cases, abnormal physiology begins or develops gradually, and it's our responsibility to be vigilant by picking those tiny details of the patient. For example, the respiratory rate or the vital signs are really vital in this case of scenarios. And the second objective is to prioritize life-threatening differential diagnosis. And as we know, a post-operative trauma patient may deteriorate for many, many reasons. And there are many differential diagnoses that we can list as a cause of the deterioration. But in that critical scenario, we cannot begin with the long list of rare diagnoses, right? We must first focus on the conditions that are immediately life-threatening, common enough, to be plausible and potentially reversible if treated rapidly. So, and the third will be to identify when ICU escalation is required, because not every abnormal vital signs require ICU admission, right? but persistent stroke or persistently worsening of the respiratory failures or even the vasopressor requirement and so on, cannot be managed safely in routine ward environment. So we have to decide whether the patient needs escalation by combining the structured scoring system that I'll be mentioning throughout my presentation. And lastly, my fourth objective is to understand the role of multidisciplinary follow-up, and my colleagues already, both of them have mentioned some of it, and I'm going to add some on top of that. So the first principle in recognizing early deterioration is this deterioration develops as a sequence of physiological changes. It doesn't happen suddenly. So the patient may initially try to compensate. This is particularly important in young trauma patients because they maintain an apparently acceptable blood pressure despite like significant blood loss or tissue hyperperfusion, right? So sympathetic activation might produce like tachycardia, peripheral vasoconstriction, and so on and so on. And in this slide, I tried to, like, for the sake of easy understanding, not just the standard actually, for the sake of easy understanding, I have tried to group the early warning signs into like respiratory, circulatory, neurological, and other clinical findings. So on the respiratory deterioration, we can easily identify by rising respiratory rate, by falling like oxygen saturations or increasing oxygen requirement might be the earliest sign of that patient is really deteriorating. So in like, for example, in hemorrhagic shock, the patient might become tachypneic partly because tissue hypoperfusion causes metabolic acidosis, right? And the respiratory system attempts to compensate by increasing the minute ventilation and lowering the carbon dioxide. And likewise, in sepsis, the tachypnea may result from fever, inflammatory activation, or metabolic acidosis, and many more. And so those things are really important, and we have to be vigilant on picking them because they are early signs of the deterioration, okay? On the circulatory, the patient might present with tachycardia and hypotension, like falling blood pressure and reduced urine output or oliguria. And there might be also delayed capillary refill, cool extremities, or rising lactate can also be found in here because, you know, on tachycardia it's actually common in many clinical cases, even after trauma, but it doesn't actually, in trauma, doesn't always attribute to pain or anxiety. It may represent like hypovolemia or in ongoing bleeding or pulmonary embolism, fever, and many more. And the key question here should be is whether the tachycardia is persistent or whether it is associated with other signs of impaired perfusion. That is the thing that we have to focus, okay? And here, the blood pressure is also important and must be interpreted carefully. And the other is on neurological signs. The neurological deterioration may appear as confusion or new onset of confusion, agitation, restlessness, or drowsiness, or even reduced consciousness. And sometimes, you know, new confusion is underestimated really, and especially in a patient who has received anesthesia or analgesic or sedatives, it's really underestimated in most of the cases. And it might be one of the earliest manifestations of the cerebral hypoperfusion or hypoxemia, okay? Or intracranial deterioration. So we have to be vigilant on that as well. In trauma patients, neurological changes should also raise concern for progression of traumatic brain injury, right? And it also might be an expanding intracranial hemorrhage or seizure activities or inadequate cerebral perfusion. So having said it, there are also other clinical signs that we can pick up in a patient of polytrauma who was operated before. So one is increasing pain. If he is conscious, if he is complaining of increasing pain, and if there is also abdominal distension or unexpected drain output, and that also might put us in a suspicion that this patient might be deteriorating. Okay, so The key message here is that we do not have to wait until the patient collapses. So we have to look for the direction of the change. All right, we have to look for the vital signs, for simple clinical examinations or for simple laboratory changes. And with that, we can see the trend of the patient, how he is progressively becoming, or is he deteriorating, or is he clinically improving. So trends tell us where the patient's actually going, and that's it. And on patients with a post-operative patient who's deteriorating, there are certain monitoring tools that we can use. It differs from countries to countries, from clinical settings to clinical settings. But in the one that's this monitoring scores that I want to stress is that none of them actually diagnose the cause of the deterioration. Okay, I want to stress on that. None of them causes. None of them diagnoses the cause of the deterioration. The score doesn't tell us whether the patient is bleeding, whether the patient is septic, or whether the patient is having anything. We don't know, but the patient, we know what we know here is the patient is deteriorating based on the score. So the first score that we use, that's first used in UK. Nowadays, it's mostly used even in our setup in Ethiopia, and that is NEWS 2, which stands for National Early Warning Score 2. And this is actually designed to identify deterioration in acutely ill adults, critically ill adults, who is using routinely measured bedside observations like vital signs and so on and so on. Easy method that we can use. And there are 7 parameters, as you can see here. There's respiratory rate, the oxygen saturation, if the patient is using supplemental oxygen or not, the systolic blood pressure, the pulse rate, the temperature, and the level of consciousness, or if there's any new confusion. So each parameter receives a score between 0 and 3, according to the degree of the abnormality, and the total score reflects the overall degree of physiological disturbance. Okay, and in general, the total score of like 0 up to 4 is low risk, and it's low risk, but still it requires appropriate assessment and monitoring throughout the stay. Okay, and the score of 5 up to 6 is important escalation threshold. It requires urgent review. We have to keep our eye on the patient because he might or she might deteriorate anytime soon. So a score of 7 or more indicates a high physiologic risk, which is it should trigger an emergency level assessment, often involving clinicians with critical care competencies. We might, based on our clinical decisions, we might move the patient to the ICU, and we have to treat that patient on the ICU level. So here, what you have to take is that a single parameter scoring 3 is also important. Okay, a single parameter that scores 3 is very important, even when the total score is not high. For example, let me give you one example. Like a profound hypotension or severe hypoxemia should not be dismissed because the remaining observations are normal. And here, NEWS 2 is useful because it is systematic. We can repeat it anytime, and based on the observations that are already collected based on the vital signs, it's very convenient and easy. The only limitation that you can find here is it is not specific to a diagnosis. It can be elevated by pain, it can be elevated by anxiety or fever or pre-existing respiratory diseases, okay? It may also underestimate the danger in some patients. So including those with a compensated shock, okay? It might underestimate in those kinds of patients. Therefore, NEWS 2 should support clinical judgment, okay? It can only support our clinical judgment, but it cannot replace our clinical judgments. That's the hot take that you should take in this. So the moving to the QSOFA, which is quick sequential organ failure assessment. Here, it uses 3 criteria, each scoring 1 point and out of 3. And QSOFA actually was developed in context of suspected infections. Okay, it's not used for all patients. Okay, it's not used for all patients, but it's an adjunct when infection is suspected in those patients. So it's not actually a primary tool for routine postoperative surveillance. And the last one is MUSE, which is Modified Early Warning Score. It is actually an outdated and older early warning system that generally includes like respiratory rate, pulse rate, temperature, systolic blood pressure, and level of consciousness. And this actually helped to establish the concept that change in routine physiologic observation can be converted into escalation system, just like MUSE, but it is traditional and it doesn't directly, like, there are certain parameters that are missing from the MUSE if you compare between the two. So it's not actually nowadays, it doesn't generally provide a more complete picture of the acute physiological deterioration, okay? So having said this, let's go to the clinical reasoning. And in as I said, in deteriorating postoperative trauma patient, the differential diagnosis is broad. However, these broad differentials are not always useful in the first few minutes of an emergency in initial assessment. So we need a structured way to prioritize in the conditions that can kill the patient quickly and that require immediate intervention. Okay, in this slide, I tried to refer them as the 5 killers. It's not categorized into 5. It's just for the sake of easy understanding and easy discussions that I've put it into 5. And the first one is ongoing hemorrhage and coagulopathy or coagulopathy. And the second one is sepsis and the septic shock. And third one is respiratory failure. 4 is missed injuries. 5, multiple organ dysfunction syndrome. So on the ongoing hemorrhage, the patient might be bleeding from an incompletely controlled surgical source, okay? We have been to the operation theater and the surgeon tried to control the bleeding, but in some cases it can be incomplete, okay? From incomplete controlled surgical source, the patient might continue bleeding. That's one suspicion that we have to have at the back of our mind. And the other reason that the patient can be having ongoing hemorrhages because of solid organ injury or because of the retroperitoneum bleeding from like the chest, from the pelvis, from the GI tract, even from the vascular injury, the patient might have ongoing hemorrhage. Okay, we have to have those possible causes in mind. And sometimes trauma-induced coagulopathy is not simply like the result of dilution from IV fluids, okay? It may begin early because of severe tissue injury and hypoperfusion, and that might trigger the coagulation process, okay? The second one is sepsis or septic shock, and it is the possibility of having that patient, the infection that is progressing to sepsis, okay? This potential postoperative source, we have also here we can also find the potential sources, okay? It might be intra-abdominal contamination. It can be like anastomotic leak. It can be infected collections, like, or it can be aspirations, wound infections, or urinary tract infections, or intravascular devices. There are multiple possibilities that the patient have a sepsis, okay? The source of the infection. So this sepsis is not simply an infection with fever, as you all know. It's it is regulated host response that is resulting from in organ dysfunctions. Okay, so the other is respiratory failure, and as a cause of respiratory failure, as I've mentioned here, it could be like the acute respiratory distress syndrome, pulmonary contusion, atelectasis, aspiration pneumonia, even pneumothorax, hemothorax. Multiple things can be mentioned under here. So we have to have our clinical reasoning in noticing and finding what is the underlying cause. And the fourth one is missed injury. Okay, I want to really stress on this one because polytrauma patients, as the name suggests, there are multiple traumas, right? And in the initial assessment actually occurs under pressure. So we've been focusing on the major traumas that the patient is under, like major life-threatening issues. But sometimes if the patient is unconscious or intoxicated or hemodynamically unstable, other like less threatening conditions might be neglected or might be missed in case of that stressful conditions. Oh, okay. So this is why tertiary trauma assessment is important after initial stabilization, so that we can go over and look for other possible missed injuries. Okay. And the fifth and final is multiple organ dysfunction syndrome, which is it's not actually usually the first event. It's the progressive sequence of severe injury or severe shock or inflammation, or it's just a final result of multiple problems. So in this case scenario, the lung may fail first, and then it might be followed by renal, then cardiovascular, and then hepatic, and then it involves multiple organs. So it's a progressive consequence of severe injuries. So I want to stress on ongoing hemorrhage, how we can have picked the earliest signs on ongoing hemorrhage. What are the clinical clues under a patient who is experiencing ongoing hemorrhage? So the clinical clues are very easy from the vital signs. We can have like the patient might be tachycardic, the patient might be hypotensive, but there might be cool peripheries, delayed capillary refill, there might be oliguria, and so on and so on. These are the clinical clues that we can pick. And one thing I want to stress is that in this case scenario, in the acute setting, hemoglobin may initially be normal. Why? Because during acute hemorrhage, whole blood is lost. That means the red cells and the plasma are lost together. So the measured concentration of hemoglobin may not fall immediately, okay? So the hemoglobin becomes more obvious after like the fluid shifts or after we resuscitate the patient, and this resuscitation dilutes the remaining blood, okay? So having the clinical clues, but the normal hemoglobin should not reassure us that the patient isn't fine or stable, okay? We have to have our clinical judgment in this kind of scenarios. So there are certain investigations that we can also send, okay? Imaging can be sent like bedside ultrasound, because we can identify free intraperitoneal fluids, pericardial fluid, or pleural collections. We can also send CT depending mainly upon the patient's stability. If the patient is stable, yeah, we can send. But if the patient is unstable, no, we just have to strongly suspect the surgical source, and we might go directly to the operative room. That's depending on the surgeon's decision. Okay, and finally, the management is resuscitation. Okay, resuscitation actually should occur simultaneously with the diagnosis. It's not like they'll stepwise upwards. The resuscitation and the diagnosis should be simultaneous. And we have to have largeable IV oxygen and so on and so on. They already have mentioned that. I'm not gonna go over that. And one thing I want to talk is the source control in ongoing hemorrhage is very important. So we have done the resuscitation and so on and so on. That's a temporary measure. But the definitive treatment in the ongoing hemorrhage in the polytrauma patient who is deteriorating is source control. Source control. This might require returning to the operating room, or even having interventional radiology or multidisciplinary actions, but the definitive treatment is controlling the source of the bleeding. Okay, so on the sepsis, I'm not going to repeat what I've said mostly here, but in the management part, antibiotics is very important in septic. So we have to send culture, right? We don't have to delay the antibiotic administration just because we have to obtain a culture, right? We have to administer antibiotics within possibly first hours of diagnosis. So after that, we have to, if the patient is also on experiencing septic shock, we have to administer fluid crystalloids, and then we have to give them first-line vasopressor, that's norepinephrine, and then we have to continuously monitor the patient. Okay, on the respiratory failure, I have already mentioned the causes: atelectasis, airides, pulmonary edema, pneumothorax, and so on. Here, the management also depends on the underlying cause. For example, let's take the patient's experiencing tension pneumothorax. On the tension pneumothorax, we have to we don't need to send imaging. That's a clinical diagnosis, right? We just have to needle decompression, and then we can proceed with the definitive management. Okay, so our management depends on the underlying cause. That's what I wanted to say. So, having said this, when should we escalate the patient to ICU, or when should we escalate our treatment or the care that we're giving? And this is actually the critical care should be involved early when the patient's like trajectory, as I've said, we have to follow the trend, right? When that trend or trajectory suggests that the patient is ongoing on having like the organ failure, we have to be vigilant on that. So we can detect the patient is having deterioration. As I've said, there are monitoring tools, right? Based on that, we can go over we have to repeat the ABCDE, and then we calculate, interpret the news too, and then we can take our management to the next level. So there is this the news to escalation pathway that I mentioned here. If it's yeah. So on the level 1, you can see the news score of 1 to 4 or 0 to 4 is just routine monitoring and observation of the patient in wherever he is or she is enough. But upon like level 2, 5 to 6, urgent review is important. We have to repeat the ABCDE, and then we have to check them hourly or even every 30 minutes. We have to check them. And then if there's the news score is more 7 or more, we have to consider ICU admission, and then we can proceed with that. Okay. Okay.
Thank you. Thank you, Miss, for your brilliance and insightful shedding light on such a critical topics in polytrauma care. Every second counts, and true patient safety rely entirely on the rapid emergency and decision maker. I would like to thank you to our all distinguished presenters for their brilliant session on such a critical topics. So, Ms. Ilham, I had just one questions for you. Let me jump into the chat box. I think this question is for the Mr. Samuel. But Ms. Ilham, could you please just told to our audience that what are the earliest clinical signs of abdominal compartment syndrome post-operatively, and when is surgical decompression mandatory?
Can you please go over the question once again?
Could you please hear me clearly?
Can you repeat your question, please?
Yeah. What should be the earliest clinical signs of abdominal compartment syndrome post-operatively, and when is surgical decompression mandatory for the patients?
Okay, thanks so much. So the earliest sign in abdominal compartment syndrome, it's actually a surgical emergency, right? So there might be the earliest actually objective sign in here is the renal change. That means the decreasing urine output despite adequate fluid resuscitation, and the oliguria of less than like 0.5 milliliters per kg per hour, or rising serum creatinine later might be the earliest sign. And then there might be also respiratory change, which is increasing peak airway pressure, difficulty ventilating, worsening of oxygenation might be also another sign. And the abdominal finding, there might be progressive abdominal distension, which is tense and firm abdomen on the clinical examination. And on the other hand, the patient might complain if they're awake, there's increasing pain, severe pain and discomfort around the abdomen. And if there's any bleeding that's continuing, there might be increased drain output that we can observe in patients with abdominal compartment syndrome. And hemodynamically, there might be also change like tachycardia. There might be also in the late findings, there might be hypotensive, and on the gastrointestinal signs, there might be also feeding intolerance. Increasing the nasogastric aspiration might also increase. So the surgery, when it is mandatory, is that when intra-abdominal pressure, we have to measure the intra-abdominal pressure, and when the intra-abdominal pressure is more than 20 millimeter mercury with the new organ dysfunction. Okay, that when that new organ dysfunction persists despite appropriate medical management, especially if there is progressive or persistent oliguria or anuria, hemodynamic instability, we might need emergency decompressive laparotomy in such case of scenarios. I hope the question is answered.
Exactly. Thank you. Thank you so much. We have great clinical questions in the chat box from Mr. Samuel. Could you please answer this? In a situation where a polytrauma patient is running hypothermic, but you are completely out of standard intervention drugs or the rescue treatments, so what alternative physical or the operational strategies can the teams use in operating room to stop the thermal declines?
Hello, was that question for me?
Yeah, sure.
Yeah, thank you.
I'm not sure I got the question. Please, would you please briefly repeat it?
Yeah,
for
sure.
me?
Actually, our audience just wrote for you in a chat box, like in a situation where polytrauma patients is running hypothermic. So what are completely like they want to ask if we are out of standard intervention drug when patient is hypothermic. So what alternative strategy could we apply for such a scenario?
Okay, if I got you clearly, how would we manage hypothermia intraoperatively?
Yeah,
right?
exactly. They want to just ask the same question.
Okay, thank you. So what I have seen being done in our setting is warming bags of normal saline and placing them on the patient's chest and various parts of the patient's body to help keep the patient warm. So not warming them so much that it can burn the patient, but just warming them so much that it can keep the patient warm. And one thing which is very important also, turning off the AC in settings where there might be a functioning AC. Turning off the AC would be very crucial in such a case. And also covering the patients as much as possible. But the main thing I've seen being done, the main things, warming bags of normal saline or Ringer's lactate and placing them on the patient's chest, on the bag, and also turning off the AC in case the AC is on. So those are alternative means I've seen people use in that context.
Thank you, Mr. Samuel. So we are out of time, I think. I would like to ask my fellow colleague to wind up the session. Thank you.
Okay, thank you so much, everyone. My name is Blessing, and I'll be giving the closing remark. On behalf of the Operating Room Global, I would like to sincerely thank our speakers for their valuable insights and our participants for joining us from across different countries, time zones, and professional backgrounds. We recognize that many of you are participating despite busy clinical schedules, varying internet access, and language differences. We truly appreciate your commitment to learning and to improving surgical and preoperative care in your local setting. Please feel free to share key lessons from today's section within your teams, institutions, and professional networks. As part of strengthening safe and effective practice globally, we encourage you to stay connected with TORG through our upcoming webinars, training programs, and research activities, which are published on our website and across our official platforms. To receive our TORG accredited training certificates, please note the following. Immediately after this section, the evaluation and certification form will open in the browser on your device and remain active for 24 hours only. Certificates are issued within 5 to 7 working days after successful submission. Evaluation is mandatory for accreditation, and certificates are linked to your TORG membership ID. Once again, thank you for being part of TORG Global Community. We wish you a safe, productive or evening ahead, wherever you are joining from. Joining us, and we look forward to supporting your continued professional development with the Operating Room Global. Thank you so much, and we'll be ending the webinar now. Thank you.